Gurleen, you may begin.
Good evening, everyone. Um, shall I begin, ma'am, or shall we wait for a couple of minutes?
Good evening, ma'am.
Okay, I think I'll begin, and then whosoever is getting in added, I will let them in. So good evening, one and all present here. I am Gurleen Kaur, and I will be moderating today's session. I welcome you all to the eighth masterclass of the series Reflection conducted by Indian Mental Health Research Center. For this, I would like to invite our speaker for today, Miss Anamika Rawlani ma'am, and the chairperson will be Dr. Reema Sinha ma'am. Thank you both for giving us your time. Thank you so much, ma'am. Just to begin, I would like to invite the speaker for the day. Ms. Anamika Rawlani ma'am is an RCI registered clinical psychologist with over 10 years of experience. She is a life member in the Indian Association of Clinical Psychologists (IACP). She pursued her MPhil from Ranchi Institute of Neuropsychiatry and Allied Sciences, that is RINPAS. She has her private practice in Lucknow, where psychological treatment is available for mental health conditions like anxiety, depression, obsessive compulsive disorder, stress management, relationship issues, learning disability, and teenage issues. Her practice is mainly inclined towards facilitating socio-economical and cognitive behavior in individuals. Her orientation is mainly mindfulness and cognitive behavior therapy. Her areas of expertise, as I have already mentioned, is likely towards anxiety, depression, learning disability.
अरे इसमें मैग्नेट वेट का है.
Can you? Yeah. Okay. We are very delighted to have you, ma'am, here. Thank you, ma'am. Moving on, uh, I would like to invite the chairperson who will be heading the session for today, Dr. Reema Sinha, ma'am, MPhil in clinical psychology. She is a licensed clinical psychologist with more than 8 years of experience, professional in evidence-based health psychology practices, therapeutic and evaluation skills, illness, or multiple stressors, sensitivity to multicultural issues, providing behavioral therapy, cognitive behavior therapy, DBT, de-addiction therapists, support therapy, and mindfulness-based therapies to her patients of depression, OCD, neurotic adults, and their behavioral issues. She's also experienced in therapeutic intervention for behavioral and emotional disorder in childhood and adolescence. She also covers assessment and therapeutic interventions for learning disorders and other childhood mental disorders. We are very, very fortunate to have. I would now request the speaker to take the session forward. Kindly remember that the session will be given 45 to 50 minutes. Post that, we will have 5-10 minutes of discussion for which we will open the session for the audience or the participants to put across any questions. Thank you.
Thank you, Ms. Gurleen, for the warm welcome. And I give thanks to Dr. Reema Dr. Geeta and Dr. Sajid and the organizers for giving me this opportunity to talk on the one of the most renowned mode of therapy, cognitive behavior therapy for anxiety, which is more prevalent now and then. We have studies all over the internet that report an increase in anxiety and depression related disorder over the last century. And CBT is definitely one of the most effective evidence-based therapy for anxiety and the related disorders. So without wasting time, I'm going to start my presentation. Um, this is such a broad topic, and I will try to summarize it as soon as possible and in the time provided. So, starting with what is anxiety? Going through some of the theoretical concepts and then giving the case scenario for the practical knowledge of the anxiety and how we can implement CBT. Anxiety is one of the most common emotions and is a normal reaction to danger or a threat. Anxiety at moderate level can be positive as it can serve to energize and motivate people to accomplish tasks and goals. High level of anxiety can often weaken and paralyze individual and cause physical and emotional discomfort. Anxiety disorders come about in part because people with a predisposition to anxiety respond to non-threatening situation as if they are dangerous. So what is the cognitive model of anxiety? The cognitive model of anxiety views anxiety as having three components. First is cognitive, emotional, and behavioral. An anxious individual perceives threats in relation to self, word, or and related to the future. The perception of threat causes a physiological reaction known as a fight or flight situation associated with many type of physiological responses like palpitations, blood pressure, dry mouth, sweating, and overall sense of high vigilance. People with intense anxiety tend to hypervigilant for signs of danger or is preoccupied with perceived danger or threat. Therefore, person is selectively tuned into looking for signs of danger when it is maladaptive. Because of the preoccupation, the person then is often unable to attend to other tasks and may complain of forgetfulness, lack of recall, and inability to self-reflect. Here I'm going to present a case scenario of a person who is walking down a dark tunnel, hearing footsteps behind him. His first thought is someone is following me, and the subsequent cognitive appraisal is they will hurt me because in the morning he read a similar incident on a newspaper. That's why he's having the subsequent cognitive appraisal. He started to begin experiencing high level of arousal in response to perceived threat, increased palpitations, sweatiness, and doubt and dry mouth. This is we call fight or flight situation. What are the emotional response which leads to this situation was frightened, feeling frightened, scared, and the behavioral response running or freezing. So here I tried to I'm trying to define a complex graph of a cognitive model of anxiety as simple as possible. So it starts with the activating stimulus, cue or stimulus, and I'm correlating it with the previous presented case. Here it was the hearing footstep behind him. So the primary threat mode activation has been activated, increased autonomic arousal, cognitive processing bias and errors, which was they will hurt me. Immediate defense, threat-oriented thoughts and images. This will lead to secondary elaborative reappraisal. It will go into a loop and a vicious cycle of more threatening and dangerous thought. And all the situation will turn to state of anxiousness. Here, it is representing the ratio between the threat and the coping mechanism. So higher the threat probability and lesser the coping ability will lead to high anxiety. Lower the threat probability and higher the healthy coping mechanism will lead to low anxiety, and last goal to the moderate. This is a graph of a etiology of anxiety. So starting with genetic predisposition, it here are the two determinants. One is biological determinant, and other one is developmental learning experience through family members, caregivers, siblings, or anyone in the family. It leads to high negative affect and trait anxiety. It further leads to sensitivity towards anxiety, sensitivity to negative evaluation, and diminished personal control. Whenever there is a stressor or aversive situation, the person is tend to be hyper vigilant, and his or her schema will be activated, which will increase the sense of personal weakness, reduce safety, and the high level of danger. This complete graph reflect a state of anxiety. Coming to the common features of anxiety. Here I'm presenting so-called cognitive distortions, which are common in most of the anxiety cases. First is minimization, which means minimizing the positives. Catastrophization, thinking worst possible scenario. Selective abstraction, focusing on a single negative aspect of an event while excluding evidence that contradicts this information. All or none thinking, seeing things in extreme. For example, only having grade A plus means I have success, otherwise I'm a complete failure. Overgeneralization, drawing global conclusion from a single or a small series of events. Vulnerability, this is one of the most important feature. Lack of self-confidence to cope effectively with the threatening situation. For example, rejection, humiliation, blame, bullying, defame, which leads to internal sign of danger. Again, here's a case scenario of a person who is social phobic or having social anxiety. So what could be his possible negative expectations? They will reject me. I will be found out as incompetent. They will think I'm weird. I can't even do the simplest things. Don't know how to do this. I will tremble and my boss will fire me. If they see how anxious I am, they will think I'm crazy. I will stumble over my words and be unable to continue. So, what are the core patterns in social phobia? In this case, self focused attention, negative self evaluation, anxious apprehensions, avoidance and escape, skill deficits, for example, lack of assertiveness, and what are the things which are amplifying or making it a vicious cycle? I'm different, rejection of anxiety, it will lead to failure errors and blowing it, catastrophization. Based on this framework of vulnerability and anxiety, two main components of this model are an enduring sense of person vulnerability, and the second is presence of hypervalent threat schemas. These are the schemas which the person has. Now, coming to the main thing, what is cognitive behavior therapy? Thought creates feelings, feeling creates behavior, and the behavior creates thoughts. So it is a combination of thoughts, feeling, and behavior. CBT, going to some of the theoretical aspect of CBT, origin and history. Cognitive behavior therapy is a psychotherapeutic approach based upon a basic idea of how one's thought affects one's mood and behavior. The treatment is based on a cognitive formulation, the beliefs and behavioral strategies that characterize a specific disorder. Both cognitive and behavioral strategies are employed for dealing with the client's maladaptive thoughts, feelings, and behavior. The treatment is based on conceptualization, understanding of individual client in terms of their beliefs and patterns of behavior. Through the treatment mode, the client is guided to bring out modification in his thinking and the belief system and bring out relatively permanent emotional and behavioral changes. Coming to the history part of CBT, in the 1960s, Aaron T. Beck, a psychiatrist and professor of psychiatry in the University of Pennsylvania, also practicing psychoanalysis, was the pioneer behind CBT. Initially, Beck coined the term cognitive therapy for his form of psychotherapy. The original form has undergone several successful adaptations in practice. However, the theoretical assumptions have remained constant. For development of the theory, Beck took reference from works of various scholars, which include early philosophers and theorists. He drew inspiration from the work of Karen Horney, George Kelly, Albert Ellis, Alfred Adler, Richard Lazarus, and Albert Bandura. Dr. Beck, while trying to testify the psychoanalytic concept of depression as hostility, turned inward, gave quite contradictory results. On dream analysis of depressed patients, Dr. Beck found that their dreams were not dominated by themes of hostility as he expected, but were more of deprivation, loss, and defectiveness, which were congruent with their actual thought content. Dr. Beck, on further dealing with the depressed patient, developed the view that such patients require assistance in problem solving, behavior activation, identification, evaluation, and response to their depressed thinking. Thus, involved the cognitive behavior therapy, which have different specification for different disorders, and the original form involved several amendments to suit the need of the patients. Beck's therapy and its variation. There are several forms of CBT that share the feature of Beck's original form of therapy, but some conceptualizations and focus in the treatment procedure vary to some degree. These therapies include REBT, Rational Emotional Behavior Therapy, given by Ellis 1962, DBT, Dialectical Behavior Therapy, Lenhan 1993, Problem Solving Therapy, Dr. Zurila and Nezu 2006, ACT, Acceptance and Commitment Therapy, Hayes, Follett and Linhan 2004, MBCT, Mindfulness-Based Cognitive Therapy, which is very renowned like CBT nowadays, Mark Williams and Zindel Siegel, Cognitive Behavior Therapy by Rezik and Shrinek 1993, Cognitive Behavioral Analysis System of Psychotherapy, McClough 1999, and Cognitive Behavioral Modification, Michigan 1977. Here I'm going to discuss only the CBT, Cognitive Behavior Therapy, given by Beck. This is a simple model of CBT for anxiety, which I'm going to define from a simple cognitive bias of a client. So it starts with the thought. It could be start with the trigger, which is real or imagined as dangerous. The thoughts could be, I can't go. I feel bad, so it must be bad. Something terrible is going to happen. This will lead to the feelings, emotions. It will affect our emotions, feeling anxious, fearful, lonely. And there will be some physical sensations of anxiety like palpitation, sweating. Again, this will lead to behavioral changes like avoidance, escape, freezing, trying to cope by doing things that help me feel better or keep me safe. So you can see that how this cognitive triad, thought, behavior, and feelings are changing the manner a client is observing the things around him. To simplify it, it starts with the early experience or our schemas. It will lead to formation of core dysfunctional beliefs. For example, I'm good for nothing. Whenever there is a stressor or a critical incident, it will lead to, again, it will go back to the early beliefs which will be activated by these triggers. It will lead to negative automatic thoughts, and further it will be less, the person will use less effective defense mechanism and cognitive distortions. It will again lead to lower self-confidence and feeling of helplessness. The symptoms are cognitive, affective, behavioral, somatic, and motivational. We are again and again using the term negative automatic thoughts. These are pessimistic predictions which tend to center on the three themes known as negative cognitive triad: negative thoughts about self, about the world, and about one's future. Goals of CBT for anxiety. One of the main goal of CBT is to help the client test whether a situation that has been labeled dangerous is actually dangerous, exploration of cognitive process. As the client is able to identify automatic thoughts, they learn that there is relationship between the occurrence of automatic thought relevant to the danger and the anxiety experienced. So I'm going to present a treatment strategy previous which we discussed a case of social phobia in previous slides. This one. So the target for treatment would be correction of dysfunctional cognitions, correction of social cost estimates and failure, focused attention, modification of the performance in the office, decreasing avoidance in social places, improving skills like assertive skills, modification of evaluation of performance, psychoeducation, cognitive restructuring, exposure, social skill training, and relaxation training. We are going to discuss all these things in the upcoming slides. So, what are the principles of cognitive behavior therapy? The basic principle apply to patients, however, the therapy differs from patient to patient in terms of nature of their difficulties, stage of life, developmental level, intellectual level, gender, cultural background, client's goal, assessment of skills, interpersonal assertiveness, etc. Client's ability to form strong therapeutic bond with the clinician, client's motivation to change, higher the motivation, higher the change. Client's previous experience with the therapy, it also have a strong association in the present therapy with the client with the clinician. Client's preference for treatment. So, what is the role of cognitive behavior therapist? For working as a therapist trained in CBT, one should be accomplished in the task of number one, conceptualization of the case, building rapport with the client, psychodiagnostic assessment if needed, educating the patient, identifying the problems, trigger, schemas, traits that which we have already discussed, exploring existing skills. For example, if the patient is having assertive skills, it is going to help us, and coping mechanism, unhealthy coping mechanism like using some kind of drugs, avoidance, escape, etc. Setting primary, short-term, and long-term goal and concerns of the therapy, application of CBT modules, and summarization. About the therapy sessions. Patients are seen once a week as a general rule. However, alterations are made accordingly to suit the patient's need. Average number of CBT sessions range from 12 to 20 sessions and may vary as per the requirement. Length of each session varies between 45 to 60 minutes. Coming to the stages in practicing CBT, there are a total of 10 stages. So the first stage is orientation to CBT and therapeutic alliance, welcoming the client politely and breaking the ice, which is one of the most important steps as the client entered the therapy room. Answering clients' initial questions and doubts, eliciting the reasons for which the client has come for the therapy, initial assessment of previous therapy experience and motivation for change. If the client is curious, explaining the process and effectiveness of the therapy. If the client is ambivalent, explaining the advantages and disadvantages of the change. If the client is reluctant, explaining whether a non-problem, for example, aggression and drug misuse, might be having some underestimated consequences. Understanding the client's expectation from the therapy. Sometimes they have unrealistic expectation from the therapy that these many things should be covered in 6 sessions or 7 sessions, which is very unrealistic for the clinician to commit to the client. Brief description of the therapy, encouraging clients' feedback on the approach, Seek client's permission for proceedings. Discuss about confidentiality. If the client is under 18-year-old, it is important to take a consent from the parents or the caregiver. Potential treatment obstacles, practical issues related to the therapy. Ensure client is happy to proceed or discuss other options like referral. Building of a sound therapeutic alliance is essential. Stage 2, which is teaching the CBT model. Teaching the cognitive model to the client through illustration of influence of thoughts on feelings or behavior. A mixture of guided discovery questions and using an educational approach like telling stories are used. Asking questions like, what is going through your mind right now? What does that mean? What if this thing would had happened? Or writing the thought feeling connection on a board is useful. It is suggestible to ask the client to maintain a clinic diary. Stage 3, assessing client's issues and suitability for the therapy. Many practitioners not necessarily apply the test or check the suitability of the CBT for the client, but this is a true issue. This is a realistic issue that every client is not suitable for the therapy. Detailed description of presenting problem, antecedent behavioral consequences, ABC analysis of presenting problem, historical analysis, assessing the suitability of the client for the therapy through administration of SRS, which is short term cognitive therapy rating scale, which is very easy to administer, a 10-item scale. A score below 25 in the scale suggests less likelihood of success of therapy. Stage 4, which is restructuring the therapy session and agenda setting. Checking the mood, review of past week's events, previous session feedback, homework review, collaborative agenda setting. Can anyone tell if the screen is visible?
Yes, it is visible, Anamika. It is visible to me.
Okay. Someone asked to define the stage
Stage
2.
2.
Yeah. Teaching the CBT model. It means here, like, we have discussed the CBT model here. This thing we have to describe it to the patient, keeping the mind his cognitive schemas, his negative automatic thoughts, what the emotional problem the client is facing at that moment, and the impact on on his or her behavior. I'm going to discuss what is guided discovery and other type of approaches to assess the cognitive beliefs and automatic thoughts of the patient. Frequent summarizing after each and every session, new goals and homework for the next session, preview of next session and client's feedback on the present session, which will hardly take last 5 minutes of the session. Stage 5, which is turning a problem list into agreed upon goals. A problem list is prepared with allocation of priorities mutually. What is client's priorities? For example, assertiveness, anger management. Problem which require immediate attention, like suicidal ideation, top the priority list. And if the client is below 18, we need to tell this thing to their caregivers or parents, despite the fact that client doesn't want it to share it to their parents. Followed by others like low mood, sleep difficulty, crisis at work, grief reaction, or physical illness. These problems can be reframed as goals, and goals should be simple, specific, realistic, and agreed upon and time appropriate. Stage 6, which is developing a case formulation based treatment plan, understanding the case as a whole and relationship between the present problems and the core beliefs. Stage 7, which is general and specific, using the specific strategies, focusing on disruptive vicious cycle of cognition, behavior, emotion, and physical reaction, maintaining the problem. Encouraging an increase in activity levels, increasing the client's confidence in the therapy by focusing on therapeutic alliance, guided discovery, using variety of verbal, imaginal, behavioral, interpersonal, and experiential strategies like thought records, weekly activity scheduling, core belief worksheet, behavioral experiments like graded task experiment, problem solving, mindfulness training, etc. This is the thought record sheet which we ask client to do this thing as to journal and to do it whenever there is, we give two options. They can do it in a SOS basis whenever there is a stress and they are not able to manage their anxiety. They are asked to write it down in the thought record sheet, and they also suggested if they can do it on daily basis. So the first column is situation or a trigger. For example, if we take the first case scenario, which was the hearing the voice from the back. Feeling emotion. We ask the client to rate it from 0 to 10. For example, I'm feeling fearful. Rate it from 0 to 10. So I am feeling fearful at the point of 8 right now. It means the level is quite higher. And the related body sensations, for example, sweating, palpitations, which are more common, feeling of shaking in the body. We can ask the question like, what emotion did you feel at that time, what else, how intense it was, so the rating can decide the intensity of the emotion, of the negative emotion. Unhelpful thoughts or images, what went through my mind, what disturbed me, what did those thoughts, images, memories means to me or say about me or the situation, what I'm responding to, what button is the pressing for me, what would be the worst thing about that or that could happen. These are the vicious cycle or the negative thoughts which are not going to help in the coping mechanism. Next column is facts that support the unhelpful thought. What are the client's schemas, the patterns, the traits which are contributing to the present problem? Facts that provide evidence against the unhelpful thought. For example, if the client is saying, if I'm only achieving grade A plus in my studies, it means I am worthy of something. If I'm getting less than that, A or B, I'm this mean I'm a complete failure. So we can ask like, what are the evidence against it? Like, how could you say that rest of the students who are achieving A or B grades are good for nothing? Are they not doing anything? So these are the evidence against the negative thought. Alternative, more realistic and balanced perspective. For example, I'm doing well. I'm trying my best. I do achieve, I sometimes I fail, sometimes I pass, but mostly I score good. So these are the alternative, realistic and balanced perspective of the situation. And what are the outcome? Like now, how I felt after having this thought against and the balanced thought. So if I was feeling fearful on the scale of 0 to 10, it was 8, it would come to 5 or 4 after doing this activity. Stage 8, application of cognitive behavior therapy techniques. Working in the main level of cognitions through number one, challenging the negative automatic thoughts, which I've already discussed in detail, unhealthy intermediate beliefs, and dysfunctional core beliefs. These are the some frequently used techniques, which I was keep on telling in my previous slides, techniques in cognitive behavior therapy for understanding core beliefs and negative automatic thoughts. Socratic questioning, it comes through, it is made through the technique of given by Socrates, where he teaches the student a particular pattern, a particular manner. It is done by clarification, challenging assumptions of the client, looking for evidence, again, evidence which is favoring the negative thought, evidence which is against the thought, negative thought, questioning again, questioning the caution. Now, what if this thing happened? What if this thing will happen? What if? So what? These type of questions. Downward arrow technique. A therapist help a client consider the personal meaning of emotionally charged thought to peel back layer of thought and reveal an underlying belief. Restructuring imagery. It enables client to try a new behavior in their mind and become more comfortable with the behavior. For example, to a client who is having social anxiety, we can ask the client to imagine a situation sitting with a person, sitting with 2 or 3 person in their mind, then actually going and doing it physically, which will enable the client to be more comfortable with the situation than directly doing it in a realistic situation. Distraction techniques, using the client's hobbies and day-to-day activities to distract in a healthy manner. For example, gymming, exercising, listening to music, cooking, using art and craft to distract oneself. Reframing the cognitive negative automatic thoughts and negative beliefs. Reattribution, decatastrophizing, exploring double standard. For example, if a statement has two meaning, um, saying no to elders is not a good thing. It means that we are disrespecting my parent. So it's a statement which has two
काम
meaning.
नहीं कर पाती हूँ
But
मैं,
we have to.
जैसे कुछ अच्छा मटेरियल आ रहा है मुझे नोट करके फिर लैपटॉप में सेव।
Can you please mute yourself? Thank you. So how can we teach the client that all the time saying no to parents politely doesn't mean that I'm going to disrespect my parent? How can we say it assertively, being polite to the parents? Thought stopping. Stopping the thought while I'm doing a certain activity. For example, we ask the client if you're using Pomodoro while studying or doing some work, for usually it is for 25 minutes. So we'll ask the client, you're not supposed to think between that 25 minutes activity. You can think about it once that session is over in your break time. So it will give some sort of control to the person who is thinking negatively, who is overthinking negatively. Guided discovery, postponing the worries. This sounds like thought stopping. If the client is engaged in cooking, for example, engaged in cooking, and the client, so what the client has to do, so he has to say to himself that I am cooking right now. Once my cooking is over, then I will think about this thought. Frequently used behavioral techniques in CBT. These were the cognitive or thought-based techniques in CBT, and these are some behavioral techniques. Monitoring one's activities, reinforcement, for example, rewarding oneself for achieving something, and negative reinforcement or taking back the reward if I'm not following something. Rescheduling the activity, uh, channelizing the day and doing those activities which we fixed with the client, with the clinician in the clinic. Graded task assignment. Here the a big task is made to a chunks of thoughts where we start with the easiest step, then going to the little higher, and then lastly going to the most toughest step. Stage 9, which is homework assignments. it goes from the very third session of the therapy. It starts with the very third session of the therapy. Homework need to be viewed by client as relevant. If the client is saying, sorry, I forget to get my clinic diary this time, sorry, I didn't get time to do the homework, sorry, I didn't get time to journal my thoughts, or I don't have habit to write, we can always motivate them to do this thing as equivalent to medicine. जैसे कि आप दवा खाते हैं और दवा खाना नहीं भूलते हैं, साइकोएक्टिव मेडिसिन, उसी तरीके से ये होमवर्क भी आपके लिए दवा के जैसे हैं. दवा हमें एक टाइम सुबह असर कर रही है, फिर रात तक उसका असर खत्म हो जाता है, हमें फिर वापस से वो लेनी है. तो पेशेंट को समझाना है, ये जो हम आपको असाइनमेंट दे रहे हैं, ये आपके लिए एटलीस्ट जितने समय तक वो थेरेपी चल रही है उसके बाद भी उतने लेवल के इम्पैक्ट डालने वाली है पॉजिटिवली, जिसको कि आप खुद मैनेज करना सीख रहे हैं. So we really can't be liberal if they are not doing their homework. ये उनके थेरेपी के लिए डेडिकेशन को शो करता है. If they are doing the homework, they are whether journaling, following the instruction, the mutual instruction and the goal. Clear understanding of homework is essential. Reviewing of homework should be done at the beginning of the session, like before starting the session, the main session. If non-compliance occurs on the part of the client, it should be responded. Homework assignment based on the cognitive component like writing a journal, coping imagery, etc. The behavior modification based homework involve activity scheduling, graded task assignments, etc. The last stage is relapse prevention. Several strategies are pursued in the course of relapse prevention, including identification of high-risk situations, rule violation effects, seemingly irrelevant decisions. This could be the possible triggers also. Increasing emphasis on positive psychology, highlighting topics like creativity, optimism, emotional intelligence, happiness, wisdom, health, and spirituality. Mindfulness training has gained much prominence in the recent times. Merging of CBT with and complementing other high quality psychotherapies whenever it's needed. Or having an eclectic approach. Managing termination of therapy successfully help in handling relapse or the follow-up. What are the possible contraindications of cognitive behavior therapy? Psychotic disorders, where there is hallucinations and delusions, organic brain syndrome, intellectual disability, learning disabilities, seizures, bipolar disorder, severe personality disorder. I'm ending my presentation with a quote given by Dale Carnegie. It is not what you have or who you are or where you are or what you are doing that makes you happy or unhappy. It is what you think about. The primary source of my presentation are these two books, Cognitive Therapy of Anxiety Disorder by Clark and Beck, and Basics and Beyond, again by Beck. Thank you. I always tell my clients to do gratitude journaling, which really help them to find some kind of positivity and hope in their life despite of having a dark situation around them.
Thank you, Anamika ma'am. Rima ma'am, I would like you to please continue.
Anamika, your presentation was very comprehensive and crisp and very specific and oriented towards every point that we need to understand about anxiety and CBT. So it was a great presentation. And I just wanted to add on to it something more. Like, for example, when we talk about anxiety, so there are different ways how we perceive anxiety that creates a difference between individuals, how they are going to respond on it. So there is another one concept around this is anxiety sensitivity.
Hmm.
And there are scales to analyze it also, which analyze it based on three core so sorry, three things, three dimensions. So if we take those also in the consideration, they help you figure out how and which way you want to take your cognitive analysis and the treatment plan.
Hmm.
It impacts that. Other than that, yes, our coping methods are to be taken in, because one of the core cognitive beliefs around anxiety is how do you perceive it as dangerous, overestimate के हम कैसे करते हैं. For example, if you see it as like, yes, I know this is stupid. Okay, I know this reason very stupid. This is not gonna happen. But should I risk it not to take any, a safety seeking behavior? That is based on the perception or my coping strategies, like you've already told in one of the slides. I remember that equations you've told us ki how it is going to lead it. Another thing that I can wanted to touch upon is CBT in children. Okay, so
Hmm.
yes, the basic core of CBT remains the same for children, adolescents, basically adolescents and the adults. But another thing we have to add on here is we might need to then increase the number of sessions at times, because we need to psychoeducate the parents where they are in their perception of how the child is going, what is going on, and what they want from the therapy.
Hmm.
And yes, how a child perceives things is somewhat a little bit different from what adults see it as.
Hmm.
So these are the few things that we need to take into consideration in CBT. There are certain limitations because of this when we are treating children, and sometimes it lands up into be more using more behavioral methods as compared to the cognitive methods.
Hmm.
So we have to analyze all of these things when we work with children around it.
To add something to it, the
Yeah.
challenges I faced while having children for the therapy. So, as the parents entered the clinic, they bombard it with the
Oh yeah.
complaints in
Yeah,
front
yeah,
of
yeah.
the child. No matter what, how many times we are telling them, please don't start with the all the time the negative comments as you entered the clinic. It certainly make the child feel that okay, मेरा clinician भी यही सोचने वाला है. अब
Yeah.
मुझे के हिसाब से डायरेक्ट करने वाला है. तो इससे चाइल्ड और क्लिनिशियन के बीच में अलायंस बैठ नहीं पाता है, क्योंकि उनको लगता है कि अभी तक मामा पापा भी नैक करते थे, अब एक और
और एक और आ गया.
है
Correct.
जो नैक करने वाले हैं.
Yeah,
Well,
completely true.
they are like mostly I've seen this kind of pattern in the parents who are basically having all or none thinking.
Yeah, yeah.
उनके
Lot
छोटे
of cognitive distortions.
छोटे improvements को they can't visualize.
Mm-hmm.
बिगर थिंग्स. इसका रूटीन नहीं ठीक है, ये 7 बजे नहीं उठती है तो सो जाती है, होमवर्क आधा ही करती है, आधा छोड़ देती है. नॉट सीइंग दैट पहले कुछ भी नहीं करती थी, अब एटलीस्ट आधा तो कर रही है.
Yeah. So before we start with a proper CBT with children, we have to bring both the parties, the children and the parents, together on the same ground, so that we are talking about the same things.
Yeah,
So that requires another few added sessions to it.
yeah.
Yeah.
If I will get an opportunity to talk on the CBT for children.
Yeah. I recently read through an article, the limitations in CBT for children.
Hmm.
So yes, it's very reflective of what we need to add on to few more things.
And the children, like not the particularly children, the adolescent,
Yeah,
aging
but
from
particularly adults.
12 to 18 years of age group.
Yeah, agreed on that. So they have different concept. They might be having an altercation with one of their parents. But yeah, this is how it is. Okay.
Someone is
Thank
asking
you.
question.
Yeah,
Someone is asking question in the comment box.
sure.
हेलो मैम, गुड इवनिंग. मैं आज साइकोलॉजिस्ट के पास लोग बहुत आना पसंद करते हैं, तो क्या इसका रीजन हमारे लेंदी लेंदी सेशन. मिस्टर मंजर, कैन यू प्लीज रीफ्रेज इट, आई एम नॉट एबल टू अंडरस्टैंड. तो क्या इसका रीजन हमारे लेंदी लेंदी सेशन
Hmm.
है.
Yeah. Mansur, you can switch on your mic and ask it also.
पसंद करते हैं कि नहीं पसंद करते हैं.
मैं
मैं
मंसूर
पसंद
हूँ।
कर रहा
मंजर, कैन यू प्लीज आस्क योर क्वेश्चन.
मैम, जैसे हम साइकेट्रिस्ट और साइकोलॉजिस्ट के पास देखते हैं आजकल लोग, अगर न्यूरोसिस के भी डिसऑर्डर हैं तो साइकेट्रिस्ट के पास जाना ज़्यादा पसंद करते हैं, ना कि साइकोलॉजिस्ट के पास। तो क्या इसका
हम्म।
रीज़न हमारे लेंथ सेशन है?
आप साइकोलॉजी की पढ़ाई कर रहे हैं?
यस मैम, मैंने एमए साइकोलॉजी से कंप्लीट कर लिया है।
आप इस बात से कितना अग्री करते हैं? तो ये मेरी अभी गाइडेड डिस्कवरी चल रही है, क्वेश्चन के ऊपर क्वेश्चन,
मैम मैं इस बात से 90% एग्री करता हूँ।
कि इसका सबसे इम्पोर्टेंट रीजन हमारे लेंदी सेशंस हैं।
यस मैम।
समहाउ मैं इससे ये भी नहीं बोल सकती कि मैं पार्शियली एग्री करती हूँ। मेरे हिसाब से ये क्विक हीलिंग टेक्निक, जो लाइक लोग सोचते हैं ना कि एक दवा खाना इज ज्यादा इजियर देन गोइंग टू अ स्लो, स्टडी एंड लॉन्ग लास्टिंग प्रोसेस। क्योंकि किसी को दवा देके उसके ब्रेन केमिकल्स चेंज करना इज वे मोर देन इजियर देन किसी को अपनी टॉक थेरेपी से उसके चाइल्डहुड पैटर्न्स बदलना, मैलएडिक्टिव ट्रेट्स बदलना, उनके कॉग्निटिव नेगेटिव कॉग्निटिव बिलीव्स बदलना। कोई ओसीडी का क्लाइंट आया है, जिसको बार बार ऑब्सेशंस हो रहे हैं, कंपल्शंस हो रहे हैं, दवा खा रहा है, वो डिमिनिश हो जा रहा है, रात को फिर उसको दवा खानी पड़ रही है, लेकिन उसका, जिसको ब्लैस्फेमी ओसीडी है फॉर एग्जांपल, वो अपने बारे में, वो बंदा कभी अच्छा नहीं सोचने वाला है कि मैं एक अच्छा इंसान हूँ क्योंकि मैं भगवान के बारे में बहुत बुरा सोच रहा हूँ। राइट? ये कौन सी दवा ठीक कर सकती है? आई एम नॉट अगेंस्ट द मेडिसिन, लेकिन बोथ द थिंग्स आर इम्पोर्टेंट। अगर बहुत सारे रिसर्च स्टडीज हैं जो बोलते हैं कि मेडिसिन और साइकोथेरेपी के साथ में चलने से इफेक्ट का लेवल बहुत हाई हो जाता है, तो मैं अग्री नहीं करती कि ये इंपॉर्टेंट रीजन है। अगेन, फी स्ट्रक्चर कैन बी अ मैटर, टाइम, डिस्टेंस, बहुत सारी चीजें मैटर करती हैं, लेकिन जब से कोविड आया, चीजें ऑनलाइन हो गई हैं, तो ये बहुत इजी है, इजी, आई मीन इजी इन सेंस अप्रोचेबल है साइकोलॉजिस्ट को कंसल्ट करना। लेकिन ये रीजन ज्यादा मिलता है अपने अपने प्रैक्टिस से कि लोग इजी अप्रोचेबल ऑप्शन चाहते हैं। मेरी एंजाइटी ठीक हो जाए एक क्लोनाज़ेपैम खा के, बजाय कि मैं ये थॉट रिकॉर्ड फॉर्म फॉलो करूं। तो ये हमारा लेंदी नहीं है, ये उनके लिए लेंदी है, उनके अपने लिए ये टीडियस लेंदी प्रोसेस है, ना कि क्लिनिशियन के लिए है, ना कि क्लिनिशियन के सेंस में है। आई होप यू गॉट योर आंसर। डॉक्टर रीमा, इफ यू वांट टू ऐड टू इट समथिंग।
It's exactly the same thing. It's just the immediate result. It's up to, there are patients like when there are parents of children, they do not want to go on to the medicines because they feel कि वो पता नहीं इसका क्या होने वाला है, आगे डिपेंडेंट हो जाएगा वगैरह वगैरह। Whereas उसको कितना भी severe हो, when you suggest कि no, this person needs medicine because this is very very high in severity, they won't go to the easily to a psychiatrist because they feel it will do something to the child. उसी जगह अभी जब वो साइकोलॉजिस्ट को ज्यादा ज्यादा प्रेफर करते हैं कि वहीं से चेंजेस आ जाए, बेटर है, इट्स अ सेफ प्लेस।
हम्म।
वन ऑफ माय पेशेंट सेड कि आप जब ही इज अ क्रॉनिक ओसीडी पेशेंट, क्रॉनिक लाइक चाइल्डहुड से है, नेवर टेकन मेडिकेशंस। He says it's better to have therapy because it's going in my head, it's not going in my stomach and doing something to my body. This was his statement about so this is his outlook. I
ट्रू।
told him, I mean, he has like severe OCD in every aspect of his life.
बट अगेन इट्स एन एक्सट्रीम।
Yeah, yeah.
We need a middle ground to live a
Yeah.
balanced
So
life.
the guideline says the CBT and medications, especially in where there are things are more chronic and severe. So ये चीजें साथ में बहुत अच्छा इफेक्टिव होते हैं।
Hmm.
And it's a well guidelines कहते हैं, it's a well established research.
Yeah, thank you, Dr. Rima.
Thank you
Uh,
so much, Anamika.
there
मैम
is one
I
more
have a question. Can
query
I
from
ask?
Shubhra.
Yes, ma'am. Good evening, ma'am.
Yes, please tell Shubhra.
Ma'am, sometimes some clients have a very sometimes when some clients comes to us and they have any stress or anxiety and we have to design like di a daily routine. You have to follow your daily routine or diary or sub journal you have to make. But clients in first session and second session he came to us that he don't follow these things, whatever we counsel for her or his, but he don't follow the diary and daily routine and these all, only they are taking medicines and they वो ऐसा सोचते हैं कि हम सिर्फ मेडिसिन से ही सही हो सकते हैं, इन सब चीजों को हम फॉलो नहीं करेंगे उनके प्रोकास्टिनेशन ज्यादा रहते हैं फॉर डेली रूटीन्स एंड डायरी, मतलब वो इन सब चीजों में बिलीव नहीं करते। बहुत सारे पेशेंट्स मैंने ऐसे देखे हैं कि वो 2 या 3 या 4 बार भी आते हैं, तो फिर हम उनसे वही फॉलो अप लेते हैं कि आपने ये रूटीन फॉलो किया था क्या, आपने अपना आपका जो डेली रूटीन था, या हमने जो भी JPMR कुछ दिया उनको रिलैक्सेशन, उनको डेमो करके बताया, उनको बोला कि आप 5 मिनट्स या 2 मिनट्स अकॉर्डिंग टू योर डेली रूटीन यू हैव टू फॉलो दिस, बट वो नहीं करके आते हैं।
हम्म।
And sometimes when they are coming at session third या fourth, तो he's like very frustrating that मैम मुझे मुझे तो कुछ आराम नहीं हो रहा है, वैसे ही थॉट्स आ रहे हैं, वैसी ही चीजें आ रही हो, तो उनको कैसे मैनेज करना है, हाउ वी हैव टू हैंडल दैट।
शुभ्रा, अच्छा क्वेश्चन पूछा है आपने, एक बहुत ही
यस।
रियलिस्टिक क्वेश्चन है। ऐसा हम लोग भी कई
यस
बार
मैम।
करते हैं कि वो एक्सपेक्ट करते हैं कि 5 इयर्स 10 इयर्स डाउन द लाइन की प्रॉब्लम्स हमारी 2-3 सेशंस में पूरी हो जाए। इसलिए केस कंसेप्चुअलाइजेशन का बहुत इंपॉर्टेंस है, साइको एजुकेशन का बहुत इंपॉर्टेंस है इनिशियल के सेशंस में। देन जंपिंग टू द गिविंग होमवर्क और टास्क और आस्किंग देम टू जर्नल। ठीक है, जो चीज पहले हमें उनको समझानी है, हम उनसे एक्सपेक्ट नहीं कर सकते कि वो खुद लिखें या खुद करें या खुद चेंज ले आए।
हम्म।
तो उनको हमको समझाना शुरू के सेशंस में बहुत इंपॉर्टेंट है। अगर उनकी राइटिंग की हैबिट नहीं है, उनका दवाओं पे ज्यादा भरोसा है, या वो खुद नहीं आए हैं, उनके घर वाले उनको लेके आए हैं, ठीक है।
हम्म।
अगर आपने ध्यान दिया होगा तो प्रिंसिपल्स में एक बहुत इंपॉर्टेंट चीज लिखी थी कि क्लाइंट का कितना इंटरेस्ट है, क्लाइंट कितने विश्वास के साथ आया है थेरेपी में,
हम्म।
उसका
हम्म।
मोटिवेशन ठीक होने का। और मैंने एक बहुत इंपॉर्टेंट बात बोली कि थेरेपी सबके लिए नहीं है, राइट।
हम्म।
जो
यस यस।
है ठीक होना डेफिनेटली उनके लिए है। अगर कोई होपलेस है तो भी हम कहीं ना कहीं होप दे सकते हैं, पर जो बिल्कुल अगेंस्ट
हम्म।
है हम उसमें बहुत हेल्प, कुछ हेल्प कर सकते हैं, पर बहुत हेल्प अगेन नहीं कर सकते। अगेन एक चैलेंज है थेरेपी का। तो
हम्म।
हमें किस टाइम पर होमवर्क इंट्रोड्यूस करना है, हमें किस टाइम पर उनको डायरी राइटिंग
ये तो
बिहेवियर।
मैम हम फर्स्ट सेशन में उनको करते हैं, जब फर्स्ट सेशन होता है तो हम उनको साइको एजुकेट करते हैं, उनका हिस्ट्री लेते हैं, उनसे बहुत सारी चीजें हम फर्स्ट सेशन में नहीं पूछ सकते।
about first session is not usually about the psychoeducation.
यस यस
ये
यस।
इलाज के
इट्स
पास,
हिस्ट्री टेकन एक्चुअली।
हाँ इट्स ये एक बहुत
यस।
डेप्थ हिस्ट्री टेकिंग सेशन है। कभी कभी तो हिस्ट्री टेकिंग सेशन में 2 या 3 सेशंस लग जाते हैं, उसके बाद असेसमेंट की
हम्म।
जरूरत होती है। लेकिन साथ में हम जब हम हिस्ट्री टेकिंग कर रहे हैं तो क्लाइंट को
हम्म।
हम उससे राइट क्वेश्चन पुट अप करना बहुत इंपॉर्टेंट है। हम क्लाइंट
हम्म।
से क्या पूछ रहे हैं जो उसे खुद भी नहीं पता था कि अच्छा ये प्रॉब्लम है।
ओके।
वो उस वक्त रिफ्लेक्ट कर रहा है कि अच्छा ये प्रॉब्लम है, वो सोच के आया है कि मुझे ओसीडी ठीक कराना है अपना, लेकिन उसको नहीं पता
हम्म।
कि चाइल्डहुड ट्रॉमास भी है, उसको नहीं पता उसके अंदर इनसिक्योरिटीज भी है, उसको नहीं पता कि उसका कॉन्फिडेंस कम है, उसको नहीं पता कि उसको सोशल
हम्म।
एंजाइटी, पर वो आया है किसके लिए, ओसीडी के लिए। तो हम जो क्वेश्चंस पुट अप करते हैं फर्स्ट सेकंड सेशन में,
हम्म।
उससे क्लाइंट को बहुत आइडिया लगता है कि मेरे क्या क्या चैलेंजेस है, क्यों थेरेपी का इम्पोर्टेंस है, और कैसे ये चीजें दवा से नहीं ठीक हो सकती हैं, क्यों मेरे लिए इम्पोर्टेंट है
हम्म।
ये चीजें करना। क्योंकि हम क्लाइंट से 7 दिन में 1 घंटा मिलते हैं। अब उस एक
हम्म।
घंटा जो उसके 10-20 सालों की प्रॉब्लम 12 सेशन में
हम्म।
खत्म, तो उसको इस बात की इम्पोर्टेंस समझानी है कि
हम्म।
इम्पोर्टेंट है। बहुत मेरे क्लाइंट्स है जो जर्नल नहीं करते, वो लिख नहीं सकते, और हर कोई आज
हम्म।
डिवाइस पे डिवाइस का ओवर यूज कर रहा है। तो आई आस्क देम टू टाइप कि आप अपने फोन के नोट सेशन में टाइप करिए, आप
स्क्रीन
डायरी,
टाइम को कम करना है, राइट।
नहीं
हम्म।
नहीं स्क्रीन टाइम को कम नहीं, पूरी बात
हाँ।
सुनिए। आप टाइप करिए, आप नोट्स ऐप में टाइप कर लीजिए, आप
हम्म।
अपना आईपैड आपका पास होता है उसमें टाइप कर लीजिए,
हम्म।
राइट। तो कोई जरूरी नहीं कि हर समय हम डायरी पेन साथ में लेके घूम रहे हैं। कभी कभी जैसे कि थॉट एक्टिविटी यूजुअली स्टैंडर्ड स्टैंडर्डाइज है कि आप रोज करिए, पर हम रोज नहीं कर सकते, तो मैं उनको ऑप्शन देती हूँ कि आप एसओएस बेसिस पे करिए, जब कुछ हुआ है तब करिए। हमने इसका बेसिक फंडा है, एक डिफिकल्ट चीज को हम कैसे मोस्ट इजी चीज में उनको प्रेजेंट कर सकते हैं। हर बार हम
हम्म।
थ्योरेटिकल स्टेप से नहीं जा सकते, हमें कुछ ना कुछ मॉडिफिकेशंस करने पड़ते हैं क्लाइंट के हिसाब से, उनकी नीड के हिसाब से, उनके सिचुएशंस के हिसाब से।
यस यस मैम।
हर चीज का कुछ ना कुछ सोल्यूशन मिल जाता है कि कौन सा सबसे इजी स्टेप हो सकता है। जब वो क्लाइंट ने अचीव कर लिया है तो हम एक
हम्म।
स्टेप आगे बढ़ सकते हैं,
राइट।
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 एग्जाम्पल, एक क्लाइंट जिसकी जीरो फिजिकल एक्टिविटी है, मैंने उसको बोला
हम्म।
कि खाली 5 मिनट घर में आप बस जब आप फोन पर बात करते हैं तब आप वॉक किया करेंगे।
हम्म।
ठीक। तो मैंने किससे शुरू किया, बहुत इजी चीज से,
राइट।
अचीवेबल है।
हम्म।
गोल्स था ना, बहुत
यस मैम।
स्पेसिफिक हो, रियलिस्टिक हो, टाइम बाउंडेड हो। राइट, तो ये वही सारी
यस।
चीजें
यस
हैं।
मैम।
तब में भी हम एक स्टेप आगे बढ़ सकते हैं।
ओके। उनके प्रोकास्टिनेशन को मतलब ठीक करने के लिए, थोड़ा मतलब इम्प्रूव करने के लिए हमें यही चीजें करनी होंगी,
ग्रेडेड
या फिर हमें
ग्रेडेड
3 or 4? यस
बेसिकली
मैम।
ग्रेडेड टास्क असाइनमेंट एक बहुत अच्छी एक्टिविटी है इस चीज के लिए।
हम्म। ओके। प्रोकास्टिनेशन के लिए।
और बहुत बार प्रोकास्टिनेशन बहुत इन डेप्थ किसी दूसरी चीज से ले रहा होता है जो चाइल्डहुड से रिलेटेड होती है, ऐसा
राइट
बहुत।
राइट राइट। चाइल्डहुड ट्रॉमा,
तो
यस मैम।
उसको फिगर आउट करना भी बहुत इंपॉर्टेंट है। कई बार जो प्रॉब्लम दिख रही है वो
हम्म।
कहने की होती है, अंदर इन डेप्थ
हम्म।
कुछ और चीजें होती है जिसको सॉल्व किए बिना हम वो प्रेजेंट प्रॉब्लम सिर्फ टेम्परेरी लेवल पे सॉल्व कर सकते हैं, डेप्थ
हम्म।
लेवल। अगेन ये डिपेंड करता है कि क्लाइंट कितने सेशंस देना चाहता है, उसके पास कितना टाइम है।
हाँ
उसके
मैम, एक्चुअली द प्रॉब्लम इज दैट कि उनको लगता है अभी 4 सेशन हो गए, फिफ्थ हो गया, अभी हमें कुछ भी ये नहीं हो रहा है, हमें कुछ भी जैसे हम थे, हमें एंजाइटी वैसी ही है, स्ट्रेस वैसी है, क्योंकि वो कुछ भी कोई भी डेली रूटीन वगैरह फॉलो नहीं करते। और आते जब भी वो सेशन के लिए आते तो पहला क्वेश्चन ये था, आपने अभी क्या प्रॉब्लम है, अभी आपका जो आप जो सोच रहे थे, जो थिंकिंग कर रहे थे अभी उसमें क्या इम्प्रूवमेंट्स है, आपने जो आपको रूटीन बताया गया था आपने उसमें से क्या चीज फॉलो करी और क्या नहीं किया। उनसे पूछने के बाद भी, बट अगर आप मैंने फोर्थ फिफ्थ सेशन में देखा है, एक क्लाइंट था, तो उन्होंने बोला कि हाँ मैंने थोड़ा किया, बट दे मतलब दे वांट टू स्किप स्केप फ्रॉम दैट देयर, कि वो तुरंत वहां से जंप कर गए और वो रूटीन के बारे में ना बात करके फिर वापस वो प्रॉब्लम के ही बारे में बात करने लगे। इस
हम्म।
तरह के चैलेंजेस होते हैं काउंसलिंग के टाइम पे।
डेफिनेटली ये चैलेंजेस हैं, पर मे बी हम शायद ये क्वेश्चन अलग तरीके से पुट अप कर सकते हैं। क्या मे बी थोड़े
लाइक।
सेशन के स्टार्ट
यस।
होने के 30 मिनट के बाद पूछ सकते हैं। देन स्टार्टिंग विद द फर्स्ट क्वेश्चन की कुछ इम्प्रूवमेंट आपको दिखा कि नहीं दिखा। क्योंकि
हम्म।
क्लाइंट सेशन के टाइम पे जैसे ही वो
हम्म।
क्लाइंट एंटर कर रहा है, वो किस माइंडसेट से आया है, उसको क्या बीच में प्रॉब्लम्स हुई, कल रात उसकी कैसी थी, उसको नींद आई थी नहीं आई थी। बहुत सारी
हम्म।
चीजें इस पर इफेक्ट डाल सकती है ना, कि वो कैसे बताएगा कि मेरा पिछला हफ्ता कैसे गया, मेरे 10 दिन कैसे गए। तो मे बी हम
राइट।
थोड़ी देर के बाद कर सकते हैं, जब वो वेंट आउट कर ले, थोड़े से नॉर्मल नॉर्मल फील करे, थोड़ा सा उसका मेरे साथ
हम्म।
टॉक स्टार्ट हो जाए, तो हम भी कब हम ये क्वेश्चन कम पुट अप करें, इसको भी हम भी डिसाइड कर सकते हैं, इसको हम भी मॉडिफाई कर सकते हैं।
ओके। ओके मैम। ओके, थैंक यू।
वेलकम।
मैम, अगर एक कोई भी ओसीडी का आपका कोई पर्सनल एक्सपीरियंस हो तो आप एक बार उसको एक्सप्लेन करोगे क्या, अगर कोई कभी भी ऐसा हुआ हो कि हाँ थेरेपी वर्क नहीं कर रही है उनपे?
Um,
एक नहीं, कई सारे
इफ यू
एक्सपीरियंस है।
हैव टाइम, कोई एक मैम ऐसा
Excuse me,
कोई
ma'am.
एक्सपीरियंस।
Do we
Excuse me,
have
ma'am.
Anamika ma'am, let's move on to the next question because we have a couple of them and then we will have to wind it up also. But definitely we can take up OCD का एक अलग से, we can keep a session definitely
yeah,
differently
Shubhra,
because
you
ओके
can
मैम,
give me
श्योर।
or you can contact on the number.
Yes, ma'am. Ma'am, Ruba
ओके
this
मैम,
side.
श्योर मैम, इफ यू हैव टाइम देन यू हैव टू एक्सप्लेन।
Ma'am,
Okay.
Ruba this side.
yeah, we will
Ma'am, there is
now
this.
come to the next question, Ruba.
Ma'am, there is this question I wanted to ask, that is there any correlation between the intellectual level of the patient and like हमारी therapy जैसे काम करती है? Can there be a possibility कि हमारी therapy ज्यादा last नहीं करे, हमारी therapeutic approach might come into like थोड़ा सा chaos हो जाए because of the intellectual level, the back and forth questioning and the way they lead us? Can there be आपको कोई link दिखा है क्या?
We have mentioned in the last slide the sorry contraindication of CBT, जिसमें कि इंटेलेक्चुअल डिसेबिलिटी मेंशन था। अब उसमें हम बहुत सीवियर केसेस की बात नहीं कर रहे हैं, वो केसेस जो स्लो लर्नर है, जिनका IQ 85 to 90 के बीच में है।
Yes, ma'am. Yes, ma'am. Ma'am, I wanted to ask like higher IQ. What about higher IQ? Can there be a problem with like counseling session? Can they be like हमसे ज्यादा argumentative हो सकते हैं कि नहीं मैंने मुझे एक और रीजन मिल गया मैम सोचने का, आपने जो वो बात बोली थी ना,
हम्म
उसकी वजह से मुझे एक और रीजन मिल गया। व्हाट
हम्म
अबाउट दैट?
बहुत अच्छा क्वेश्चन है। क्या नाम है आपका?
रुबा, रुबा खान।
बहुत अच्छा क्वेश्चन है आपका, रूबा। डेफिनेटली ऐसा हो सकता है, बहुत पॉसिबिलिटीज और कई बार देखा भी गया है। जब क्योंकि सीबीटी इज मोस्टली अबाउट लॉजिक्स, एविडेंस, तो
यस।
हम सजेस्ट और क्लाइंट की सजेस्टिबिलिटी डेफिनेटली वन ऑफ द इम्पॉर्टेंट फैक्टर है कि हमारी थेरेपी कितनी इफेक्टिव होने वाली है।
ओके मैम।
तो अगर हाई आईक्यू है तो काफी चांसेस है, ऐसे कई सारे केसेस में देखा गया है,
हम्म
सच कहते हैं कि उनके लॉजिक्स हमसे ज्यादा हैं,
हम्म
एविडेंस उनके फॉर ज्यादा है, अगेंस्ट कम है।
हम्म
उनका अपनी चीजों पे बिलीव ज्यादा है बजाय के क्लिनिशियन की चीजों पर,
हम्म
राइट।
हम्म
उनमें टाइम ज्यादा लगता है चेंज करने में,
हम्म
कुछ भी थॉट लेवल का चेंज लाने में,
हम्म
राइट। पर ऐसा सारे केसेस में तो नहीं है, पर कुछ केसेस में डेफिनेटली ऐसा देखा गया है।
हम्म
उनकी सजेस्टिबिलिटी टू चेंज इज वेरी डिफिकल्ट।
ठीक है ठीक है। ओके मैम, थैंक यू सो मच।
बट
Yes,
अगेन,
Anamika, I agree on what you just said.
या बट अगेन ये कंट्रीब्यूटिंग भी हो सकता है, क्योंकि वो जब हम उनको बोलते हैं ऑल्टरनेट थॉट जनरेट करो, तो वो बहुत
जी।
अच्छे थॉट्स के साथ प्रेजेंट हो सकते हैं, और
हाँ,
पॉजिटिव थॉट्स। तो ये दोनों के लिए लाइक दोनों चीज
लाइक
है,
वन केस,
और
लाइक,
impact होता
यस,
है।
जस्ट मैं थोड़ा सा टाइम लूंगी। एक केस आया था वेयर लाइक साइकेट्रिस्ट से बात हुई, तो शी वाज टॉकिंग टू वन साइकेट्रिस्ट, वन कंसल्टेंट। तो उन्होंने बोला कि लिथियम और ये लेनी है, तो और दूसरी नहीं लेनी है। वन साइकोलॉजिस्ट सेड कि आपको एसिटोपाम, आई डोंट नो द नेम, वो नहीं लेनी है, लिथियम बस लेनी है, ठीक है। तो शी वेंट इनटू दिस सेल्फ डाउट कि मैं अभी तक की जो मेडिसिन ले रही थी, क्या वो गलत थी, और जो दूसरे डॉक्टर ने बोला वो ठीक है कि नहीं। बिकॉज इन डॉक्टर ने बोला कि तुम ज्यादा सोचती हो। तो एवरीथिंग वेंट क्लैश्ड, लाइक सब चीज एकदम क्लैश हो गया।
हम्म
तो व्हाट अबाउट दिस?
ये कहीं ना कहीं हेल्थ एंजाइटी, डेफिनेटली हेल्थ एंजाइटी को
हाँ,
शो कर
यस
रहा है।
मैम, यस मैम, यस मैम।
सिग्निफिकेंट लेवल की हेल्थ एंजाइटी है, तो अगेन हम इसको सोमेटोफॉर्म डिस नॉट
ओके ओके ओके
में हम लोग इसको मेंशन कर सकते हैं।
ओके ओके ओके, थैंक।
गूगलिंग अबाउट द मेडिसिन, द सिम्टम्स, ये भी
हम्म। एंड शी
अ,
इज डॉक्टर एज वेल, लाइक एमबीबीएस कर रही हैं।
हम्म
तो इस वजह से पॉसिबिलिटी है कि शी इज ऑल्सो अवेयर ऑफ दोज थिंग्स।
डेफिनेटली एक एक इम्पॉर्टेंट फैक्टर है।
ओके, थैंक यू सो मच मैम।
वेलकम।
Thank you, Anamika ma'am, for that.
थैंक यू।
Uh, I would now request Rima ma'am that can we conclude the session, or shall we wait for some time with
Yes.
your
Anybody has any more questions, we can. Otherwise, we can conclude.
sure.
Just, I guess, one or two more questions. I I
I
don't
believe,
think. Uh,
yeah, let us conclude. Okay. So I, Gurleen Kaur, clinical psychologist, director MP, IMHRC, would now like to extend a very warm thank you to both uh, the guests who were invited today. Thank you for gracing us with your time and knowledge. And also a very big thank you to the participants. Thank you for joining us for this masterclass.
thank you.
थैंक यू, थैंक यू एवरीवन।
Thank you.
थैंक यू मैम।
And